Assalamu alaikum. I welcome you all to the Sarcoma and Reconstructive Surgery session of the symposium. So we are fortunate to have a diverse line of experts to present their talks in the session. We have got experts from medical oncology, orthopedic surgery, plastic and reconstructive surgery, who will share their insights and experiences in managing this complex disease. So without further ado, we'll call the chair and the co-chairs to the stage. Let me invite Dr. Masood Umar, who is the consultant and professor of orthopedic surgery and head of department at Aga Khan University Hospital, Karachi. Sir, can you please join on the stage? With him will be joining Dr. Kamran Khalid, who is the head of department and professor of plastic and reconstructive surgery at Jinnah Hospital, Lahore. And Dr. Ilyas Rafi, who is the head of department and orthopedic surgeon himself, who works at Shaukat Khanum Cancer Hospital at Lahore. So without further ado, let's invite our first speaker, who is Dr. Afshan Ali. She is a consultant pediatric oncologist at King Faisal Specialist Hospital, Medina, Saudi Arabia. She is a diplomat, American Board of Pediatrics and Pediatric Hematology and Oncology. Her special interest is in pediatrics solid tumors. It'll be a virtual talk, so let's.
Assalamu alaikum and good afternoon, everybody. First of all, I'd like to thank Dr. Usman Ahmed and Dr. Mohammed Faisal and the organizing committee, as well as the leadership of Shaukat Khanum for planning this wonderful symposium and also for inviting me to speak. And a specific thanks to Dr. Naeem Butt for being patient and waiting for the presentation and the slides. So I thank you for that. Now, I was very excited to be able to be part of this session, but the original plan was that I would be talking about soft tissue sarcomas as a general, and I think the 15-minute time slot would probably not allow me to do service for that category, as it's very broad. So I thought that I would talk to you a little bit about Ewing sarcoma, a few updates, and then give you some of the experience that we've had at our organization at King Faisal Specialist Hospital in Riyadh in terms of how we've managed these patients and what our outcomes are. Additionally, we have started seeing these same patients in Medina and are trying to follow the similar protocols and treatment plans. So we'll go ahead and start now. And I have nothing to disclose in terms of conflict of interest, and we'll move right into the plan for the presentation. Initially, as you all know, James Ewing in 1921, he was a pathologist. He described Ewing sarcoma, and then over time, Ewing sarcoma started developing into several subcategories. So one was the Ewing sarcoma or Ewing tumor of the bone, extra-osseous Ewing, primitive neuroectodermal tumors, and then Ewing-like tumors. The epidemiology is fairly straightforward. These comprise for about less than 5% of all soft tissue sarcomas and are the second most common primary bone malignancy seen in adolescents and young adults. The peak incidence for this tumor is usually between the ages of 10 to 15, and about 30% of these kids are less than 10 years of age, another 30% over 20, and then the rest are all in between. There is a male predominance, and about 20 to 30% of these patients will present with metastatic disease at the time of initial diagnosis and presentation. The workup and staging is fairly standard. I'm not going to go into too much detail because of time, but a couple of important things. Plain films are very important. And sometimes you will get a lot of information, particularly now if you have extremity tumors and you need to later on do measurements and things like that. So plain films are very good, in addition to the MRIs and the CT scans that you will be doing. CT of the chest. Most of the centers where PET CT is available, they have replaced the bone scan with PET CT. But if you don't have PET CT, then the bone scan is very valuable. Regarding the type of biopsies that we do, traditionally open biopsy was the way to go, but now more and more, we are using our interventional radiology colleagues to help us, and core biopsies are obtained just to make sure that we have representative tissue and we have adequate tissue so that molecular studies and so on can be sent on them. And finally, I wanted to talk about one thing, which is the serum LDH. It is a prognostic factor, and many times we forget to look those up or to have those labs drawn. So I think a serum LDH would be very important as a baseline, and then to follow it if it is elevated. And then fertility counseling for the appropriate patients who need it. Now, one of the things that has happened over time is that the Ewing classification has changed a little bit. And now we all know that the most frequent gene rearrangement is the T1122Q24. And then the second most common is the T2122Q22. And then there are some other ones that you can see here. But recently, in the 5th edition of the World Health Organization publication, they redefined Ewing sarcoma based on the fusions between the EWSR1 and the ETS family of transcription factors. So this is now very interesting. We have now 3 tumor groups recognized among Ewing-like sarcomas: the sick rearranged sarcoma, the sarcoma with B core genetic alterations, and the round cell sarcoma with EWSR1 non-ETS fusions. So I think that things are becoming a little bit more clarified and more detail-oriented. One of the other interesting things about these Ewing-like tumors that have been reclassified is that not only do they have different molecular characterizations, but also there are specific immunohistochemical markers that are able to be used for diagnostic purposes. And this is really important because morphologically, these tumors are differentiated like phenotypically, and then immunohistochemistry is available. And in some places where you don't have access to molecular diagnostics, I think that this will be very helpful in determining the type of tumor it is. And here's a simple table that will give you all the different subtypes, Ewing, sick, rearranged, B core, etc., and how they will differ and vary. And then here's another format or another version where you basically have an undifferentiated small round cell tumor. And this is a little bit of a pathway for our pathology colleagues and for us when we look at our reports to say that based on, this is all morphology here. And then after that, some staining and some other evaluations and further delineation in the lab. And then we go to the FISH for the translocations, and then NGS, and then eventually, based on those results, compiled with the information here, we're able to pick out and define the type of tumor that we have in the Ewing family. So I think this is very important. Now, very quickly, a little bit about the historic perspective of treatment for these tumors, and what are a few basic premises that we need to take home with us. Number one is that the event-free survival in the Ewing 8893 studies clearly demonstrated that the tumor, when their tumor size is large, i.e., they said greater than 100 mLs, the surgery plus radiation had a better event-free survival, for example, 60%, compared to radiation alone, where the event-free survival for large tumors was only 29%, and this was statistically significant. So this is a very important point. The other hallmark study was in 1989, ES79, where Hayes and al. Published that tumor size greater than 8 centimeters versus less than 8 centimeters had an impact on the disease-free survival. So for example, tumors that were less than 8 centimeters, they had an 82% 3-year disease-free survival. And tumors greater than 8 centimeters had only 64% disease-free survival at 3 years. So this was very important, the tumor size. Then in the ES87 protocol, Paul Myers et al. Used an upfront window, ifosfamide BP16. And what they found was that there was an overall response rate of 96% using this window. So that was incorporated into the backbone of therapy. And then in 2008, a very important study, COG protocol AEWS 0031, the results were reported in ASCO by Womer et al. And basically, that clearly showed that compressed cycle chemotherapy, i.e. 2-week interval treatments for these patients, improved outcomes. And based on that, we also at King Faisal decided that we would make that changeover. Now, the protocol here, this is the protocol design for the AEWS 031, and basically the regimen B, which was the Q2-week therapy, became our standard of care across the most of the North American areas, and now also for us. One of the main issues with that, and we made that switch over only in 2012, and this change was a little bit concerning because people were worried that the patients were coming in very poorly malnourished, emaciated, and they would have more toxicity with this Q2-week interval cycles. But we did not find that. And actually, our morbidities and mortalities have been not super high with this regimen. So I'm going to now take all of that into account and give you a quick summary of our review and analysis thus far. What we decided to do is look at survival analysis in 2 groups of patients based on treatment period. So from 2005 to 2012, the data that we had patients on for Ewing sarcoma therapy were getting Q3-week therapy, versus 2013 to 2019, where pretty much everyone had switched over to interval compression, vincristine doxocyclophosphamide alternating with IFOS-VP every 2 weeks. So it is very interesting because you can see that while we don't have a statistical significance in the overall survival for all comers, 5-year overall survival is 66%. In the first period, and in the compressed cycle period, 79.6, almost 80%. But in the event-free survival, we do have a statistical significance of p-value where we've got in the first period event-free survival only 45%, but in the second period, 76%. One of the other things that we did do is that for our metastatic disease patients, and you'll see that later, we went ahead and put them also on maintenance chemotherapy in the second period. Now, again, you look at it based on localized disease, and you can see quite significant in period 2. Again, p-values maybe are not there for the overall survival completely, but it's 0.057. But here in period 2, we have 5-year overall survival 92%, and similarly here event-free survival 92%. So this is very helpful and important information. And then we look at metastatic disease, and in the overall survival, you don't see any major differences. But here again, in the event-free survival, the p-value is 0.048, and you can see that there is a significance in outcomes improvement with an event-free survival rate of almost 46% versus 23%, so increased by 2. So this is the information that we have, and based on that, we said this treatment regimen that we're using, compressed cycle, is tolerable, and also with the maintenance for our metastatic disease, we are having good outcomes. So then we went to our experience from 2012 to 2021. We took 89 patients and we reviewed their outcomes through retrospective chart reviews with the cutoff of age 14 years. 10 patients were excluded, 67% metastatic, non-metastatic, 33% metastatic, And you can see the overall survival and event-free survival curves are comparable, 77 and 56%. The tumor sites did not have any impact on event-free or overall survival. However, when we looked at the disease by staging, we found that both the overall survival and event-free survival were impacted and had positive p-values. And we can see that the non-metastatic 5-year overall survival was 91% and event-free survival 72%. And then for the metastatic, we have overall survival of 42% and then event-free survival of 19.4%. The metastatic sites did not have much impact, but bone was the worst. And then if you look at this data and you benchmark it against the SEER data, we are very comparable. King Faisal has almost the same, if not a little bit better outcomes on benchmarking. So in summary, using maintenance therapy included for metastatic disease, irinotecan, temozolomide for up to 1 year after the end of the first backbone therapy has been very helpful and improved event-free survival. Reclassification is ongoing right now for these patient cohorts to identify further molecular characterization and use of liquid biopsies. Finally, for future direction, PCR detection of cells and looking at disease burden. And my favorite, potentially the use of CAR T cells in Ewing sarcoma. One of the major issues is that right now we have only some preclinical trials with a couple of ongoing trials, but I think it looks very promising and technically should work. So again, reclassification of Ewing sarcoma to further define bad actors based on molecular characterization, identification of high-risk patients based on the above, so that adjusting tailoring therapy could impact outcome, improved analysis of disease burden, more defined molecular profiling, and continued development of targets to improve regimens. I want to thank everyone, and this is my latest slide from SIOP, the latest picture I took, and this is our team in Riyadh, and I have to say that we all work very well together and in concert, taking care of these patients. I'm sorry I won't be there for questions or be part of the panel, but wishing you all the best and hopefully see you next time. Thank you very much. Bye-bye.
Thank you very much, Dr. Arsha. We'll take questions at the end. So let me invite the next speaker. Our next speaker is Dr. Masood Umar, who is a graduate of Aga Khan University Hospital, and then he completed his specialist degree from the same hospital in 1998. He has got multiple fellowships under his belt, including adult reconstruction, joint replacement, Elizarov surgery, and orthopedic oncology. Currently, he is working as a professor and head of department at orthopedic surgery at Aga Khan University Hospital. He has got multiple publications, over 3,000 citations. He has authored 2 books and numerous book chapters. So let me invite Dr. Masood Umar, who will be talking about biological reconstruction and limb salvage surgery after sarcoma resection. Thank you.
Thank you for the kind introduction. Bismillahir Rahmanir Rahim. Allahumma salli ala Sayyidina Maulana Muhammadin wa alihi barik wa sallim alayh. Sorry. I was informed about 20 minutes, but I would try to squeeze it in 15 minutes. Anyhow. So thanks to my mentors, today where I stand is because of them, starting from Professor Umar, Franklin, Annie King himself, and David, and then the first course we organize, and our alumni have a big role to play in becoming a team with me. So in the next 15 minutes, I'll be dwelling on the subjects of autoclave tumor bone, vascularized or non-vascularized fibulae, parental fibular allograft, Warnes rotation plasty, suspension plasty, our experience, and then a combination of these two. Initially, I would begin with presenting you some data of pure biological reconstruction being done in our unit. And that comprised of last 8 years, about 49 cases, a retrospective review, year-wise distribution, province-wise distribution. Minimum age was 3, maximum of 61. Most of them were pediatric patients, most of them were males. Upper limb, mostly lower limb, and all across the body, sometimes presenting with a fracture also. Mostly were osteosarcs, mostly were primary tumors, wide excision mostly, and we use the following options, which I will dwell in the next few minutes with actual cases. We had our share of problems, and those are most difficult to manage when you are doing limb salvage surgery. Patients have to have, as the previous speaker alluded to, go to adjuvant chemotherapy. You have to manage their infections and their wounds within the finite 3-week period. We had fractures, we had broken implants, we had malunion, non-union, thrombosis also. So about 80% are still alive at minimum of 3 years of follow-up. So we published this in 2014. In the absence of a bone bank, we are using fresh parental allografts from their parents, be it the mother or the father, and we test them for communicable diseases, and that's it. Don't do tissue typing. And we have done about more than a dozen of such cases whereby in the absence of bone bank, we need structural allograft. And this is a fresh allograft being provided by a strong fibula, either the mother or the father, and I'm using mostly in pediatric patients where you need initial skeletal stability. Their own fibulae are very thin to provide that. So as an example, this was a young boy, presenting in 2009 to me, right from in this region, from Gujranwala, with the tumor of the distal femur, where it was encasing the femoral artery and the vein in the thigh, right? So somebody had done attempted excision or partial excision in the thigh, as you can see from the scar. And this is what we did. We had to excise the scar and the vessels and the bone as a composite tissue. This was the reconstruction. His father's fibula was used as an augment to the autoclave bone, and then we fixed it with LCP, and my vascular surgeon colleague fixed it with PTFE grafts. This is immediate post-op. This is about 10 months later. About 6 years later, he broke his plate, secondary to non-union. We revised it, did quadriceps plasty also, did bone grafting, and then he was lost to follow-up. And then this is just yesterday, I saw him, and he has about 90-degree motion. His leg is about 2 inches short here, and he has an equinus, fixed equinus. And this is he broke at the top also, and somebody in Lahore fixed him. And this is how he walks now. He has an unstable foot and ankle on that side. He manages the shortening by the equinus gait, but he's well into the society. He's completing his D-Pharm now and is very happy with the outcome. Doesn't want any more surgeries to be done. So we published in 2006 in the core about our experience of autoclave tumor bone for adults, and then I published in this Biomed International about our experience of autoclave bone in the pediatric patients, right, as a low-cost alternative. And basically what we do is devitalize the tumor bone, remove soft tissue, remove the marrow, and then autoclave at 130 degrees for 10 minutes. Adults, 8 minutes for pediatrics, and then reimplant after soaking them in antibiotic solution. Just to highlight a case of distal femur sarcoma, that's the planning, that's the incision, excision. This is how we get to the native bone after autoclaving, removing the tumor tissue that was present here after a wide clear margin surgery. Reimplanting the tumor autoclaved bone back, fixing with a metal device, and then doing a plastic surgery vascularized fibula along with the skin by my plastic surgery colleagues. That's the final reconstruction follow-up. This was a 9-year-old boy from Sialkot who has initially, I think, treated at Shaukat Khanum at the medical oncology department. That is one of the reasons I especially looked out for him. This is the pre-operative MRI. So wide excision, autoclave tibia, bone reinsertion, and a fibular flap. This is the tumor excision, autoclaved bone. That's the defect left, very thin, small piece of proximal fibula being visible here, proximal tibia visible here. Just below the knee joint, we preserved his knee joint, did a kind of a marginal resection just above his physeal plate. That's the specimen resection. So as you can see that we have spared the physis, gone just above that with the saw, and so that we have a clear margin, although that of very few millimeters, and then reimplanted the bone back, fix it with a Phelos plate. For a very small child, we use Phelos plates, which are used for shoulder, and then multiple screws in multiple directions, and also use the fibula, free fibula with the skin. This is follow-up. Then he developed lung mets, which were excised in due course of time with thoracoscopy and wedge excision. And I also saw him yesterday right here in Lahore, called him, this is the final X-ray, and he can walk with some shortening. He's developing equinus there, reasonably good range of motion. So the attachment of patellar tendon really works out well. So you have to work on that. You initially remove the patellar tendon, you have to reattach. And this knee motion is a function of that. Although he has reversal of the tibial slope, that'll need correction when I will do the lengthening. Hopefully, he's still a bit close. I want a 5-year follow-up, disease-free follow-up, and then I would succumb him to a lengthening procedure. 15-year-old girl, osteoblastic osteosarcoma. Here again, you see periarticular bone sarcoma touching on the physeal plate. Physeal plate acts as a biological barrier against the spread, and MRI confirms that. We give chemo, and now we are ready for surgery. This is what we end up with after tumor resection. If you focus on the picture on the left, a very thin amount of proximal tibia left. Tumor, this rest of it is tumor bone. We are excising, making the cut above the physis. And then I'm rebuilding the tibial metaphysis with direct structural autograft from the iliac crest, fixing it with Herbert screws, and then autoclaving the bone and putting it back. And this time here, we did not do that. We just only used fibular struts as pillars to the medial and lateral plateaus, and then fixed it with the plate. So 8 months, 4-year follow-up. The metaphyseal bone has healed. The fibular grafts have healed. This is how she walks. This is her knee bending and the knee extension, the function of patellar tendon. So in upper limb, this is a 9-year follow-up of a case of giant cell tumor of the scapula, which we excised completely and did a suspension plasty with fiber tape and now Arthrex tape we use. So passing through the humeral head and the clavicle, a repair was performed, but it got loose. As you can see, the humeral head going down. We had to go in and revise the repair. And this is the scar, and this is the function of the patient 9 years down the line. Suspended, the upper limb totally suspended on the lateral edge of the clavicle through small tapes. This is 9 years down the line. He's engineer in interior Sindh. He has very reasonable function. He can eat, he can do his hair, he can wash his face, he can even scratch his back. Yeah, that's it. Another example, a 5-year follow-up of again a suspension plasty done after scapulectomy, where the kid was able to do push-ups and see and show us the range of motion. He was able to eat, although he had some trick movements of the upper limb. He was able to do good internal rotation. And this is at 5-year follow-up. Oneness, when the tumor is much bigger, especially of the distal femur or the proximal tibia, oneness was a technique described for a near total amputation where you would either save only the nerve or save the vessel and the nerve and just remove everything. So here is the index case where I was perplexed. The vessel was involved. I was only able to spare the nerve. This is rhomboid incision for oneness, and that's the excision. So I cut the skin only from posterior side. I dissected out the sciatic nerve seen here in the picture on the left, dividing into two, common peroneal and posterior tibial, and then the excise everything else. And then you bring this is the tumor specimen X-ray, and you bring the leg back, rotated 180 degrees, either fixed with a nail or a plate, and this is the end result, right? So the ankle joint serves as the knee joint of the patient. After a prosthesis, you can have reasonably good extension and flexion at the knee joint. We published this experience, 2014. This is my last slide. Again, a young boy from Lahore who had a combination of autoclave tumor bone, his mother's fibula, revision, some shortening, it was very reasonable function. And he was, again, very happy with the outcome despite some shortening and limitation of knee flexion. So biological reconstruction is possible, especially in pediatric age group. That should be, and that is the procedure of choice. It is durable and it is lifelong. I've shown you 15 years follow-up for some of my patients, and they don't have any problem with their functional life. They're very happy with their living right now and are very functional members of the society. So principles of resection have to be followed. You may be very marginal at times, but then your med-onc colleagues, your radiation-onc colleagues need to chip in. Adjuvant therapy has to have, and we need to work like a team, which would include plastics and vascular, for you to be able to achieve difficult resections. Approaches have to be innovative. Your bone cuts have to be very accurate. I don't have navigation in orthopedics, but I'm reasonably confident after doing these procedures. Obviously, navigation may be the future. And what we have learned is to have more stronger fixation techniques. We have had some plate breakages, so maybe double plating now, or stronger plate use, or a bigger plate, longer plate usage. Thank you for your attention.
Thank you, Dr. Masood Amar. Our next speaker, which is going to be a virtual talk, is by Dr. Farooq Shehzad. He is an associate professor of plastic and reconstructive surgery at Memorial Sloan Kettering Cancer Center in New York. He graduated from Aga Khan University Hospital, Karachi, and then completed his general surgery residency and plastic surgery residency at US. He has multiple fellowships under his belt, including craniofacial pediatric plastic surgery and reconstructive microsurgery. So Dr. Farooq Shehzad will be talking about reconstruction in chest wall sarcomas.
I'm Farooq Shehzad, and I'm a plastic surgeon at Memorial Sloan Kettering Cancer Center in New York. I'm also a visiting consultant at the Aga Khan University in Karachi. When we talk about oncologic reconstruction of the chest wall, there are a few important principles to consider. The most important principle is that 100% of the wound needs to heal 100% of the time. And what that means is that these patients are going to get, a significant number of them are going to get adjuvant therapies. And so the reconstruction has to be reliable and durable, because even if there's a small problem with healing of the wound, their adjuvant therapy is potentially going to get delayed, which will affect cancer prognosis. The second important principle is that the prosthetic reconstruction of the chest wall requires stable soft tissue coverage. Again, even if there is a small problem with wound healing and the prosthesis gets exposed, that can be a big problem, and it could be a problem that we cannot solve. When we think about reconstruction of the chest wall, there are three important things to always consider: the external soft tissue resurfacing, the internal skeletal support, and obliteration of any potential dead space. This third point is frequently ignored, and it's important because dead space will result in accumulation of fluid, which can result in infection, which again can be catastrophic. Now, in terms of skeletal support, the purpose of skeletal reconstruction of the chest wall, in addition to protection of the thoracic viscera, is to prevent paradoxical movement. And what that means is that the segment of the lung moves in opposite direction of the rest of the lung tissue, which means with inspiration, as the intrathoracic pressure decreases, the lung moves inwards, and with expiration, the lung moves outwards. What this does is it creates a ventilation perfusion mismatch of that segment of the lung, which impairs respiratory mechanics. And if this defect is large enough, it can result in respiratory failure. Now, for skeletal reconstruction, there are many materials that have been used. You can use rigid material or semi-rigid material. You can use biologic or prosthetic. There is no consensus on the ideal material to use, and the choice frequently depends on the experience of the thoracic surgeon. Now, in terms of soft tissue reconstruction, which is the focus of this talk, the chest wall has traditionally been divided into three zones: the central chest wall, the anterolateral chest wall, and the posterior chest wall. And the reason for this division is that classically, locoregional pedicled flaps are used for soft tissue reconstruction. And by dividing the chest wall into segments, you can choose which flap would best reach that part of the chest wall. Now, the traditional workhorse flaps for thoracic reconstruction are the pectoralis major flap, the latissimus dorsi flap, the rectus abdominis myocutaneous flap, and the greater omentum. For the vast majority of thoracic defects, these flaps are sufficient and they do very well. However, there are situations where these flaps are either insufficient or unavailable. And those situations are when patients have had previous operations and these flaps have been transected, when these flaps have previously been used and the patient has another problem or a recurrence. These flaps are, again, they may not be usable. If a patient has had radiation and the flap tissue itself or the pedicle has been radiated, and sometimes they're not usable in that situation. Or if there's a defect that is larger than the ability of one of these flaps for reconstruction. In that situation, we would use a free flap. Now, at Memorial Sloan Kettering Cancer Center, we have shown that when we use free tissue transfer, we are reconstructing defects that are larger than those we reconstruct with traditional pedicle flaps. We have a higher rate of complete resection and a low rate of local recurrence. Now, how do we choose what flap or what tissue to use? Well, that depends on three things. Number one is the defect, the size of the defect, and the location of the defect. The second is the available recipient vessels in the area. And the third is the available donor sites. And this depends on the patient's body habits. Out of all of these, the recipient vessels is the key to microvascular reconstruction. Now, for the purposes of free tissue transfer, instead of dividing the thoracic cavity into zones, we divide it into recipient vessel territories. So the central chest wall is reconstructed with recipient vessels, which are the internal mammary vessels. For the lateral chest wall are recipient vessels of choice are the thoracodorsal vessels. If for some reason these vessels are not available, then our second line options are vessels in the neck or the thoracoacromial vessels that are present in the upper chest. The posterior chest wall is significantly harder to reconstruct. The posterior lateral aspect of the chest wall is in the territory of the thoracodorsal vessels, so those are the vessels we choose. However, as you go towards the posterior midline, you don't have great recipient vessels. And in those situations, for the upper thorax, we frequently have to do vein grafts to neck vessels. And in the lower thorax, we frequently have to do vein grafts to the thoracodorsal vessels. Now, we'll discuss some examples of these cases and how we tackle these complicated situations. So this case is an example of a 38-year-old male who has been diagnosed with spindle cell carcinoma. His history was complicated by the fact that he underwent a NUS procedure as a child because of pectus. He then developed spindle cell sarcoma. He was taken to the operating room by the thoracic surgeons. They did a clamshell thoracotomy, resected this tumor, which involved the sternum, the costal cartilages, the central parts of the rib, also involved part of the lung, the mediastinum. So he underwent a lung resection, and he was left with this big defect. Now, this defect is not amenable to any local regional traditional pedicle flap options. The pectoralis major muscles have been resected. The rectus abdominis muscles are not available because the internal mammary vessels have been transected, and the omentum is not going to cover this entire defect. It's not big enough. And so this patient requires a free flap for durable reconstruction. In these situations, our flap of choice is a vastus lateralis myocutaneous flap. And the reason for that is you get a large amount of muscle that you can use to cover the prosthesis, and you also get a significant amount of skin that you can use for resurfacing. I always assess the perfusion of these flaps using indocyanine green angiography. What that means is the anesthesiologist injects ICG intravenously, and then we use a camera to detect ICG in the tissues. Tissues that are white means that they're getting ICG, which means they're perfused. Any tissues that are dark are not well perfused. We simply excise the portions of the flap that are not well perfused so that when we do the reconstruction, everything that we use is going to be healthy, and so we don't encounter wound healing problems. The internal mammary vessels are dissected out and prepared, and we hook up the flap to the internal mammary vessels. Now, a problem with doing these large flaps is that you get a large donor site. So this is this patient's thigh. It's about a 30 by 15 centimeter donor site. You could simply skin graft this, or what we do is we'll put an external tissue expander in. And what this does is it stretches out the skin over time. And in this patient, it took about 23 days. I've taken back to the operating room, take off the expanders, close the skin. Skin looks a little bruised at 6 weeks, but at 10 months, it's completely healed. And so this looks long-term much better than a large skin graft, and it avoids another skin graft donor site. This is a patient who has a radiation-induced sarcoma of the chest wall, comprising the anterior chest wall as well as the anterolateral chest wall, and underwent a big resection, including multiple ribs. The thoracic surgeons did skeletal reconstruction with titanium mesh. We harvest a vastus lateralis myocutaneous flap. Now, this is a lateral defect. So naturally, we would go to the thoracodorsal vessels. However, this patient has had a previous axillary dissection and radiation, so the thoracodorsal vessels were not available. The internal mammary vessels were also not in an ideal location for this flap, and so we did vein grafts to the transverse cervical vessels in the neck, and this patient went on to heal. Here's an example of an elderly patient. So this is an 80-year-old patient, again, radiation-induced sarcoma, has multiple comorbidities, is frail, so we don't want to do a very complicated operation. So in this patient, we choose to do a left-sided rectus abdominis myocutaneous pedicle flap. Now, anytime you do a rectus abdominis pedicle flap, you should always dissect out the deep inferior epigastric vessels before you ligate them. And so this is what we did. We bring it through a tunnel into the defect. And after we do this, we see that the perfusion is not optimal. And so we're not happy with the way this flap is bleeding. Now, what we can simply do is just take those dissected deep inferior epigastric vessels and supercharge them to the internal mammary artery and vein. And this results in dual flow of this flap. And in spite of this patient's comorbidities and radiation, she went on to heal. Here's a slightly more complicated defect. This is a gentleman with a myxofibrosarcoma. We all know that myxofibrosarcomas are diffuse tumors, so they leave a large defect. So this patient had a resection of multiple ribs, as well as part of the lung. We look at all his donor sites. He's a fairly thin gentleman, so he doesn't have a big thigh, but he has a lot of laxity in his abdomen because of weight loss. And so we choose an ipsilateral rectus abdominis myocutaneous pedicle flap. Now, before doing an ipsilateral rectus flap, you have to make sure that the internal mammary vessels have not been transected, which they weren't. Bring the flap up, and after we do so, again, we're not completely satisfied with the way the flap is bleeding and with the perfusion. And so we simply supercharge this to the thoracodorsal vessels, which results in excellent flow of this flap. Here's an even more complicated defect. So this is a 45-year-old gentleman with a myxofibrosarcoma, has undergone a previous resection, as you can see from his scar, underwent adjuvant therapies, radiation, has another recurrence. He was actually sent to us by another cancer hospital who told him that he was unresectable because this would leave a very large defect that may not be able to be reconstructed. Anyways, he presented to us. Our thoracic surgeons took him to the operating room. He underwent resection of this tumor, including 6 ribs and lower 1/3 of the scapula, leaving this big defect. Skeletal reconstruction was done by the thoracic surgeons using polypropylene mesh and ribs created with methyl methacrylate. We dissect out his thoracodorsal vessels, which we use as recipients. We use a large vastus lateralis myocutaneous flap, and we hook it up to the thoracodorsal vessels. And this patient went on to heal, received more adjuvant therapy, and is been cancer-free for about a year. Here's a young patient with a desmoid of the anterior chest, but it's a low anterior chest, so it's the bottom part of the chest wall. So he was taken to the operating room, underwent resection by the thoracic surgeons. They took out 6 ribs, skeletal reconstruction with phasix and acellular dermal matrix. Phasix is an absorbable mesh, and the ribs were then reconstructed with methyl methacrylate. And then we did soft tissue reconstruction with a vastus lateralis myocutaneous free flap. This defect is a little low for the internal mammary vessels, so we vein grafted to the IMAs, and this patient went on to heal uneventfully. Now, these posterior defects, as we discussed earlier, are very complicated. And so this is an example. This is a young patient who had a spindle cell sarcoma, has undergone 2 resections, a closure, radiation, reconstruction with a rotational flap from the back, has another recurrence now. So he is going to be taken to the operating room for a very big resection. Again, this is a complicated situation. We can make this simpler by staging the reconstruction part of the operation, because that's going to be the most complicated part of this operation. So what we do is we take him to the operating room. and we do an AV loop. So take a greater saphenous vein graft, hook it up to the facial artery and vein, and we park the loop close to the defect. Then a week later, we bring him back to the operating room. First of all, we confirm that this loop is open. This is an implantable Doppler. And this Doppler is telling us that this loop is still flowing. So once we have that information, we ask our neurosurgeons and surgical oncologists to excise the tumor. The tumor is excised, leaving this large defect. And then reconstruction was performed with a latissimus dorsi myocutaneous free flap connected to this AV loop. We chose a latissimus dorsi because the patient was prone for this procedure. Unfortunately, this patient developed another recurrence. He underwent an excision and closure, more adjuvant therapy. Unfortunately, this patient passed away recently because of his disease. This is an example of a patient with an even more complicated situation. So this is a gentleman with a history of a Pancoast tumor who's undergone upper lobectomy, resection of multiple ribs in the past, spinal fixation, underwent reconstruction in the past with trapezius flaps, supraclavicular flaps, multiple revisions, and now has a chin on chest deformity. So this is a very complicated situation. This requires revision of the hardware. However, he's going to need stable soft tissue coverage if they are going to revise the hardware. So again, very complicated situation. We can simplify this by staging it. So this operation was done over 3 days. The first day we do an AV loop. We connect it to the thoracodorsal vessels. The second day he was taken to the operating room by the neurosurgeons who revised the hardware and correct his deformity. And on the third day, we take him to the operating room and we do an anterolateral thigh free flap and connect it to the AV loop. And this actually went on to heal, and the patient is doing well. So in summary, oncologic reconstruction of the chest wall is a multidisciplinary approach, which requires close communication and cooperation of thoracic surgeon, plastic surgeon, anesthesiologist, critical care physician, and nursing. We have a multidisciplinary team here at Memorial Sloan Kettering, and so all of these operations are done with close coordination. The reconstruction has to be reliable and durable because these patients, significant number of them, need adjuvant therapy. And for that to happen, the reconstruction has to be completely stable. Microvascular reconstruction has been a game changer for us, and it has allowed us resection of larger tumors in a more reliable fashion. Thank you very much.
Thank you very much. Those were some really complex cases. Next up is Professor Dr. Kamran Khalid. He is the professor of Plastic and Reconstructive Surgery at Janab Burn and Reconstructive Surgery Center in Lahore. He holds a specialist degree in plastic and reconstructive surgery and has got over 20 years experience in the field. His areas of expertise include microvascular surgery, hand and upper limb reconstructive surgery, and sarcoma management and reconstruction. So over to you, Professor Kamran.
Assalamu alaikum. Thank you so much for your introduction, and special thanks to the organizing committee, the chair and the co-chair, and especially my friend Samiullah for inviting me and continuously pursuing me for the last 2 months for this talk. So we have a very enlightening session with the virtual talks and then a very nice and elegant reconstruction shown by Professor Masood Umar. So I will restrict my talk mainly to the soft tissue reconstruction in sarcomas. So until 1970s, not very recent past, the main treatment of sarcoma when encountered in a limb is an amputation. But now we are saving almost more than 90% of the limbs. And that attributes to our better understanding of tumor, its pathophysiology, the new improved imaging modalities, and the new adjuvant radiation and chemotherapy, And last but not the least, the advancements in the reconstruction techniques so that we can achieve a good function after sarcoma resection. So limbs are basically affected more in sarcomas, and almost 60% of sarcomas occur in limbs. So the presentation of patient in our society is basically, in one word, it is a late presentation. The contributing factors are, if it's nature of the sarcoma, it's a slow growing, painless swelling, and people usually ignore it for quite a long time. And when they present late, mostly the deeper structures are already involved, and that make its management even more difficult. The second common mode of presentation in tertiary care centers are basically the recurrent tumors. Initially, either excision being done, considering them as a benign lesion, or incomplete resection being done. So these recurrent tumors poses another challenge, because, as you know, now the management in the management of recurrent tumors, the excision margin have to be wider. The spread of the disease is very erratic. Maybe there is a tumor on one side of the section margin, and the other swelling is present on the other side of the section margin. So a very wide local excision have to be done. The anatomical planes are destroyed, which are basically the barrier for the tumor spread. So it becomes quite difficult to manage these recurrent tumors. Initial assessment of the patient is very important, because that is the time when basically you set you set the theme, okay, what you are going to do for this patient. Either it's going to be a salvage, or you are going for a palliative or amputation. When the patient present initially, the swelling is painless, but usually on presentation, either there is some pain due to nerve or pressure symptoms, or there is edema or restrictive movements due to either muscle involvements or bones and joint involvements. So you have to assess first which is the plane of the tumor from where it is arising. Either it's a bone tumor, it's arising from the muscle, or more superficial structures. If they are arising from the muscle, you have to ascertain which muscles are basically involved. And either it is on a single muscle that is involved, or multiple muscle or compartments are involved. Then nerve involvement usually present as numbness or pain in the nerve territory, then vasculature, then bone and joint involvement. Although the metastasis in the sarcomas is mainly hematogenous, but you have to also look for the regional lymph nodes, because 5 to 7% do metastasize to the regional lymph nodes. In soft tissue sarcoma, MRI is the preferred investigation. That is the treatment of, that is the first choice investigation for me. Obviously, for bone sarcomas, X-rays and CT are also useful. Then there are adjuvant further investigation, which we used to do to see the metastasis of the spread of the disease. Then the biopsy we do after we have done the imaging and investigation, so that we have a clear understanding what is the extent of the disease. Because once the biopsy done, all of the planes, they are disturbed. So the first choice is the core needle biopsy. And if there is some doubt, or there is still no result, then we move on to the incisional biopsy, but in select cases. And then comes the patient counseling in sarcoma, resection and reconstruction. And I think this is the most important part, which is essential for a good doctors and patient relationship. And because you have to tell the patient what is the disease, how extensive it is, and what will the resection margins, and whatever reconstruction you will do, there will be some functional loss. So the patient should be on board. And then the reconstructive option you are going to use to again to reconstruct the defect, and then the stage procedures, need for radiotherapy, and almost in all patients there is a long rehabilitation. So your patient should be on board and well consult before you start this, before the management of this tumors. So the theme of management is to maximize the long-term recurrence-free survival. And you do the investigation to minimize the morbidity of your resection. And the final reconstruction is basically to maximize the function again. Nowadays, 1 to 2 centimeter of surrounding normal tissue is considered adequate, followed by radiation. For major neurovascular structure, if they are displacing the nerves or vessels, stripping of adventitia or perineurium from the nerve is considered adequate. Similarly is the case for bones. If it is abutting the bone and not eroded it, stripping of the periosteum is enough. Prognostic factor for local control is obviously your surgical safe resection, surgical resection margin, but for metastatic risk, the histological type and grading of the sarcoma is the main determining factor. So like in this case, the tumor was just pushing the neurovascular bundle. So adventitia of the vessel and the perineurium was stripped, and obviously closure and coverage and closure was done, followed by radiation. So when we go for limb salvage, although every patient has an individualized plan, but there is a rule, like there are five structure basically in a limb: skin, soft tissue, muscles, nerves, vessels, and bone and joints. So if 3 structures are involved, there is always an indication to salvage the limb. But if 5 structures are involved, usually amputation is probably the right treatment for that. But if 4 out of 5 structures are involved, then there is a gray area. One can go for salvage of the limb, reconstruction if facilities are available, patient is fit enough. So, but whatever is the mode of treatment and reconstruction, it should never compromise tumor resection. So again, now we will discuss each soft tissue one by one, okay, how they are reconstructed. So skin and soft tissue. The number one is if you can achieve a tension-free. The point is to tension-free primary closure. Sometimes the skin is expanded due to large tumors and you can close it. But if not, then the second option is to use loco-regional flaps. And if these are not available, then we resort to free flaps. Like in this case of sarcoma involving the vasa medialis, skin was not involved, so we were able to achieve primary closure. But in this case of a recurrent tumor in axilla, after excision, the brachial plexus was exposed. So a pedicle flap was used to cover it. It was loco-regional flap, a parascapular flap was used to close this defect. And then this type of tumor, like in this tumor section, there is a large soft tissue defect, tendons, nerves are exposed, and no loco-regional flaps available. So we reconstruct it with free tissue transfer. Then comes the vessel. Obviously, whenever the vessels are involved, we have to take the segment out. And the vein grafts are the mainstay of treatment. But sometimes there is a loss of vessel as well as skin. So in this case, flow-through free flaps are basically there to help us. So this is an example of vein grafts, like in reconstruction of ulnar and radial artery. And this is an example of a flow-through flap. So you can see here, this is basically, this is scapular parascapular flap, and this is the proximal end of the subscapular artery, and this is thoracodorsal artery. So this vessel can be used to maintain the continuity of the vessel, and basically this circumflex scapular artery that will perfuse our flap. And this is the anastomosis being done here from the radial artery, this proximal end here, and this distal end here in the anatomical snuff box. Then comes the nerves. Obviously, the goal is to restore the sensation and maximize the function. If the segment is lost, the nerve graft are the answer. But if it's very proximal, we can also resort to distal nerve transfers, like in radial nerve. This is one example in which after resection, there was a median nerve loss, and once there was coverage was achieved, the median nerve continuity was maintained by nerve grafts. And this is in lower limb where part of sciatic nerve had to be sacrificed in the section, and it was reconstructed by nerve grafts. Then comes the muscles and tendons. For muscles and tendons, one option is to use tendon grafts or tendon transfers or functional muscle transfers, which can be either pedicle or pre-functional muscle transfers. Facial atta is a very useful recipient donor for tendon grafts, especially in lower limb in 10-HLS reconstruction or foot drops. But for flexor tendon reconstruction or extensor tendon reconstruction in upper limb, we usually need multiple grafts. In that case, long extensor tendon grafts are quite useful, like in this case, or in some ancillary procedure. So I'm going to show you a case which shows all the reconstructive technique we have still discussed. It's a 22-year male with a 10-month history of synovial sarcoma over the median malleolus. And on MRI, basically the posterior tibial vessels and nerve that was involved, along with the tendo-HLS and long flexor tendon of the toes and foot. So, and mass was also abutting tibia. So this was the axial margin. We always use frozen section in our resection because we have to reconstruct and we have a adjoint to reassure that our resection is complete. So this was the resection. This is the defect created. And this is the tendo-HLS reconstruction with facial atta graft. And then posterior tibial nerve was reconstructed with nerve grafts, and the posterior tibial artery continuity was maintained with this free ALT flow-through flap. So this is follow-up after 6 weeks, and this is follow-up after 9 months. So for bones and joints, we need initially a temporary external or internal sprintage. Bone graft for smaller defects, but today we have seen that even larger bone graft can be used. But for the larger bone gaps, a vascularized bone flap is the gold standard because a vascularized bone graft will heal just like a normal fracture. It will grow with the patient. If there is a young child, it will grow with the patient if you have taken the epiphysis with it. So this is the example where a distal arm synovial sarcoma involving the elbow joint and distal humerus. There was some cortical breach of the humerus. So this was the resection, and we have to resect part of marginal humerus. And the joint capsule was excised. Joint capsule was reconstructed with a vascularized facial atta and the coverage with a free tissue transfer. And then this is a case of a young boy which was operated for osteosarcoma of upper humerus. And now he presented to us after 2 years. His radiation and treatment was complete, but there is a bone gap of humerus and there was no shoulder joint. So we decided to maintain the bone continuity with free fibula, and we reconstructed the shoulder joint with fibula head. So as you know, usually the fibula is raised on peroneal vessels, but in this case, we have to use the head of the fibula, anterior tibial vessels have to be used. So it is raised on anterior tibial vessels, and the bicephemorous tendon and collateral tendon was taken to suspend it. So this is the X-ray, and you can see this is the 3 months follow-up, and patient lives in a far-off place in KPK, and he is now using rocks to do the physio. So another case in which there is a young girl with a pleomorphic sarcoma involving the shoulder. We have excised it and we delayed till we have the final biopsy report, histopathology report. We reconstructed it with ipsilateral lepidopsis dorsi myocutaneous flap. This is the follow-up. But unfortunately, it recurred within 6 months. So once again, we have to excise it, but this time the excision margin have to be very white. And this was the defect after excision. The trapezius, the scapula, the deltoid, the rotator cuff, all the abductor mechanism of shoulder that has to be excised. So we decided to reconstruct it with contralateral free LD as a functional muscle transfer. So this was the LD functional LD flap, and this is after 1 year, patient can have a full abduction of the arm. This is another case. He came from Afghanistan, and he was twice excised the tumor, but it again recurred, and amputation was advised, the 4-quarter amputation for this patient. When we studied the case and did the investigation, we were lucky enough that we were able to get tumor-free resection, but this was a huge defect, and all the anterolateral muscles are gone along with the knee extensor muscles. So we reconstructed it vertical rectus abdominis muscle flap VRAM, function VRAM. As you all know, it has a segmental supply. So we use the nerves of the rectus vastus lateralis and rectus femoris to motorize it. This is the immediate post-op, and you can see after radiation, he has a good functional regain, and there he is walking. So thank you. This is the take-home messages that the tumor resection and reconstruction is essential and very rewarding for the patient. But for that, you need a meticulous planning and execution. And one can't do it alone. You have to make teams. And the way forward is to establish sarcoma management center or at least specialized team, because that is how we can improve our patient care. So thank you very much.
Thank you very much. Have we got any questions for any of the panelists?
I'm Dr. Zuha. I hope everyone can hear me. I'm one of the senior registrars at Shaukat Khanum. My question is for Dr. Masood. Sir, you have shown more cases of autoclave bone in reconstruction for biological reconstruction. So do you have any experience with liquid nitrogen treated bone? Like in Shaukat Khanum, we are doing more liquid nitrogen treated reconstructions. So my first question is that. The second question is, as you know, when we do a biological reconstruction lower limb in young patients, so what happens is there is a limb length discrepancy. So have you by now encountered a patient which you have to address the issue either by using a Lizarov method or anything else, fixator or transport of bone segment by any method to address the lower limb length discrepancy?
There are 4 methods of reusing a tumor bone. One of them is autoclaving, 2 is liquid nitrogen, 3 is pasteurization, and 4 is irradiation. Right? You can use either of them. All 4 have proven their worth in literature, although pasteurization is hardly used out of Japan anymore. But autoclaving we have published multiple times. Liquid nitrogen seems to be getting more popular since it provides, perhaps in the studies, more strength. But I think it depends on which technique you have a command on, right? So I published that paper in 2006. It is almost 20 years ago, and we were using it since 5-6 years before that. So I have a huge experience, and now for me to shift on another technique just for the sake of it, I can produce equally good results, which I have shown and published with an autoclave bone. Regarding second question, yes, I am also an Elizarov surgeon, but I wait for 5 years. I haven't done lengthening below or proximal to 5 years, firstly because of chances of tumor recurrence, and then to really assess that their leg length discrepancy or expected leg length discrepancy would go beyond 5 centimeters. So the moment that happens after 5 years of index surgery, I would do their lengthening.
Okay, thank you.
I have a question with Professor Masood. Very nice presentation. I'm Dr. Amara. I'm a plastic surgeon. My question is regarding you showed biological reconstruction for the grafts, parental grafts, parental fibula. You showed in a pediatric group. I wanted to ask if what are the prerequisites regarding the immunogenicity regarding an allograft, as we are transplanting a parental fibula to a pediatric group, and also what is your experience in adults, because you showed these were pediatric group patients, and if you have any experience with the adults as well and the prerequisite for using such parental flaps.
So immunogenicity का दिखाने का मकसद ये था कि इसमें immunogenicity नहीं होती. Although we asked parents कि भाई if you've had either hepatitis or anything else, and they would be very honest, it is going inside their own child, so they wouldn't hide it from us, and then we can test it from the lab. So what we have seen is this is a non-vascularized transfer, so it doesn't pass through the hematologic system of the body as would any other transplant go. Right? So this is a piece of dead bone implanted for initial skeletal stability. And we have shown over time that it does heal also, provided you have vascular ends, your ends are vascular at proximal and distal ends, right? And provided you provide enough metallic support to bridge that. Obviously, we have had infections, and I showed my number of complications. We've had breakages, we've had instances where we had to remove that autoclave bone as a dead substrate, a rich substrate for bacteria. But anyhow, having said that, that goes with all devitalized tumor tissue options that I mentioned, 4 of them, right? For adolescents, we have used it not for adults because their own fibulae are strong enough. Right? So we have rich, ample bone graft substitution, bones, fibulae, iliac crest, and other substitutes which can suffice in adolescents or bigger adolescents and younger adults. So mainly this is restricted for pediatric population, younger pediatric population.
Any more questions?
Assalamu alaikum. My name is Mohammed Hamza. I'm working as a senior instructor in plastic surgery in Shaukat Khanum Hospital. My question is for Dr. Masood Umar. So very nice talk, and you have shown a wide experience regarding the biological reconstruction after salvaging limbs. So just I want to ask one thing that you have shown a lot of methods of biological reconstruction. Just want to know your experience regarding using alloplastic bone materials or bone cements in limb reconstruction, using a combination techniques, and how is your experience that?
होता तो मैं आपको दिखाता. I have no experience of using bone cement as a substitute for bone defects. So that's a temporary, very temporary usage, would break with time if patient starts to walk on it, especially in the lower level. That's my general feeling, so I have never used it as a substitute for bone defects. वो कभी, in adults in metastatic disease, yes, there is a place when you can augment it with metal rods around, cement around metal rods or around the plate even, and fill the defect in either humerus or tibia with a cement and pass a rod around it or a plate. But that's in advanced metastatic disease where the patient unluckily may have a few months to live. So those are not very lasting reconstructions to me.
And so another question is that in proximal humerus sarcomas involving the proximal humerus, and if you're replacing it with a vascularized fibula, either based on peroneal vessels or as Dr. Kamran mentioned, an anterior tibial vessel spaced. So what is your mode of fixation? Either you use small DCPs or longer plates. What is the best
जी
method?
वो जो सर ने दिखाया ना वो probably he arthrodes the upper end of the fibula with the scapula. Am I right, sir?
We take the bicep femoral tendon and along with the for suspension of the
Yes.
fibula, we use the bicep femoral tendon along with the fibula head. So it was basically weaved and fixed to the acromion.
Mhm.
And secondly, collateral ligament, they were also weaved in the capsule. So that provided the stability.
Yeah, we do the same. Any tendon or mostly the synthetic fiber wire or tiger wire. अब तो ये बड़े strong आ गए हैं तो ये use कर लेते. Even I have used this thing
Palmaris?
Palmaris and even half of Proneus also as a supplement to my reconstruction, especially in adults जहाँ limb बहुत भारी है उसका initial support चाहिए आपको. You only have clavicle left, you have done a full scapula, no acromion, no glenoid, right? So only thing left is the humeral head and the lateral end of the clavicle. So उसको आपको फिर multiple directions में hole बना के I use a tape and a tendon now together. So that's what I.
So third question, just if Dr. Sami allows me, I have a lot of questions regarding because you have very vast experience and it is.
Hamza, this should be the last question.
Yeah, it is for both Dr. Kamran and Dr. Masood that we just have a patient we discussed recently in an MDT with Dr. Elias that he has a sarcoma involving the whole of the calcaneum in the heel, and they are planning. It is not invading the vessels, but it is salvageable. But I just want to know what are the options to reconstruct the whole calcaneum, and if the Achilles is excised, that what are the best options or the preferred technique to reconstruct a calcaneum if calcaneum is excised. And the kid is 10 years old, so I mean the medial epicondyle is.
I think vascularized iliac can be one option as it has a good stock and it can provide the support which is needed. So so basically DCIA flap that can be used, I think.
And Dr. Masood, your take on this?
We have done about 3 of them, I think 4 of them. 2 failed because of technique and 2 have survived. So the deep circumflex iliac runs just about 2 centimeters below the internal edge of the iliac crest. So you have to dissect that from the femoral and then harvest the whole iliac crest depending on the length. You can fracture it, you can have it at right angles to provide more surface area. And you can use skin with it also, depends on the section. So that is a very good flap, which can provide support. And the ones we have done successful, patients are quite happy.
They are able to walk and.
Yeah, well.
Thank you. Yes, sir.
Dr. Elias wants to say
But
something.
Umar is doing this new flap of medial condyle of femur. I think that can be also.
Right, right. A very nice session on the third day of the symposium in the afternoon. I thought everybody would be asleep or maybe just running away, but it's very encouraging to see the house full. I have a list of questions for Professor Masood and Professor Kamran, but I think we'll do it over a cup of coffee after this session. And thank you very much, everyone, for coming and making this so wonderful session, for your interaction, and special thanks to all the guest speakers. And thank you very much.
Thank you very much, Dr. Masood, for coming all from Karachi, and Dr. Kamran. We are very thankful to you as well. And this concludes our session. Do you want to ask any question now? Dr. Amara? Dr. Amara wanted to say.
The same question. You said it's a parental avascular bone graft. So what normally we say 3 to 4 centimeter of avascular graft in adults. the vascular grafts, bone grafts. How about in children? I think they were very large grafts. So I want to ask, what are the limits? What are your experience? How much avascular parenteral bone graft are successful in children?
No limits actually depends on the resection level. ठीक है? That length of the donor graft is dictated by the resection defect that you will create, and that is you do preoperative planning through MRI. ठीक है? So
Normally, after 3 to 4
there's no
centimeter,
upper
maybe normally go for a vascularized
3 or
bone.
4 cm. हाँ, वो
Yes.
vascularize की तो यहाँ कोई possibility नहीं है ना.
Pediatric groups, you have a good experience with the larger
Usually
avascular
enough.
grafts.
It's a huge bone fibula for peds. जितना छोटा बच्चा हो तो उसकी अपनी फिबुला बिल्कुल तिनके की तरह है. So उसके लिए माइक्रोवास्कुलर वाले भी जरा हेजिटेट करते हैं, लेकिन हम अब कर रहे हैं. Youngest we have done is a 3-year-old where we have done a vascular fibula. So, but then that cannot be left alone like this. It has to be supplemented with some stronger skeletal structure, which in my opinion, parental fibula is a very good resource. अब बच्चों इतने 3 साल के बच्चे में आप इतनी बड़ी प्लेट भी कहाँ से लाएंगे? हमारे पास तो नहीं है ना. सो जो प्लेट्स हैं सारी वो अडल्ट की हैं. हम तो वो शोल्डर की जो छोटी प्लेट 3.5 को रिवर्स करके लगा. बाद दफ़ा तो उसकी भी जगह नहीं होती. मैंने वो आज आपको एग्जांपल, यू ओनली यूज के वायर्स. In a 3-year-old, you are only left with K-wire or Steinman pin at max to have a diaphyseal support. So implantology is very limited, especially the younger the patient is. So this is a reasonably good option that we have, and we have published that.
If we
If you
even
can find the
go 4 to
JPMA
5
2014, I published that experience.
Okay, even 4 to 5 to 6 centimeter, even avascular fibula will survive in the pediatric group.
It would never survive. Ultimately, it will either incorporate into the host bone or be rejected by way of resorption, right?
that's why they need some-
Self-resorption. But the point is that hardly produces an immunogenic reaction. So we are safe from that. I have experience of more than a dozen cases now, at least 15 cases now. So there's hardly an immunogenic issue. So we are kind of safe from that side.
Thank you.
Thank you very much.
Thank
This
you.
concludes our session. Thank you.
Thank you very much.